4, and in children it could only be performed after the discovery of dual source CT scanners. So why was this? So what does a 64 slice CT scanner mean? So suppose the craniocaudal dimension of the heart is 14 centimeter. With one, in a 64 slice CT scan, with one rotation, suppose the machine covers 4 centimeter of the heart and the craniocaudal dimension of the heart is 14 centimeter. So the CT machine needs at least 4 rotations to cover the whole heart. Now, as the number of rotations increases, the scan time increases, and with that, the radiation dose also increases. So, from 164 slice CT, when we moved on to 128 slice CT, the CT machine could cover the whole heart in two rotations. So the scan time was further reduced. And now with dual source CT scanners, we are able to cover larger volumes of the heart even with a dual source CT scanner means that there are 2 X-ray sources which both cover some part of the heart, and so we are able to cover more volume of the heart in a single rotation, and so the scan time has been significantly reduced as we'll see later. So as it started, we started with a 4-row multi-detector CT, to 16-row, to 64-row multi-detector CT, and now a 128-row multi-detector CT. And as we increased, the scan duration significantly reduced with time. So with 4 slice, with a dual source CT scanner, the scan time is less than 1 second. So as we see with a 64 slice multi-detector CT scanner, the scan time was almost 27 seconds. And with a 27 second scan time means that we'll ask the patient to hold breath for almost 27 seconds, which is difficult even for adult patients. For pediatric patients, it will be even more difficult. But now with dual source CT scanner, especially the flash machine that sir has here and we also have in our institute, we have been able to reduce the scan duration to less than a quarter of the second. So now we can perform these scans even in pediatric age group, and the radiation dose, as we can see, has been reduced from 1598 in milligray centimeter to 211.9 milligray centimeter, which means less than 1 millisievert. So we are able to get images with very good spatial resolution, temporal resolution, and within the radiation limit that has been prescribed by various societies. So in a dual source CT scanner, what happens is that there are two sources of CT scan which both cover half of the volume of the heart, and so even in very less time we are able to cover the entire volume of the heart. And so to perform a coronary CT, particularly in pediatric age group within the prescribed radiation limits, it is not only important that the protocols are right, it is also important that we have the right hardware of the machine, like this dual source CT scanner. So in which a large area is covered per gantry rotation. So this allows, so what happens is that as we know in coronary CT, the prerequisite, we often give beta blockers to control the heart rate. So why is this important? So usually it is said that the heart rate should be less than 60 to get a good image in adult patients. Why? Because cardiac CT is done with ECG gating. So what ECG gating does is that we try to image the heart in the phase of the cardiac cycle in which there is least motion. And this phase of the cardiac cycle is usually the RR interval. As we reduce the heart rate, the RR interval increases, and that is why we get more time to cover the heart in that in the time of the cardiac cycle in which the motion of the heart is least. But with dual source CT scanner, even with high heart rates, we are able to image coronary arteries with very good spatial resolution. It also allows motion-free images of exceptional quality because we have been able to reduce the scan time to less than a second. Breath hold is also not a problem in performing these CTs, and feasibility for radiation limitation to the prescribed levels of less than 1 millisievert. So to perform a successful CTCA, which allows us to image coronaries and get good images for adequate interpretation, first we have to know the indications why the scan is being performed, because radiation exposure is involved, so the scan must be justified. We must have the KFTs of the patient renal function test report because of contrast-induced nephropathy which can occur. Next is patient preparation, peripherals. All this will be discussed in the later sections. But as we discussed earlier, beta blockers are given usually to the patient not only to control the heart rate, but also to prevent any arrhythmia that occurs during the performance of the CT scan, ECG electrodes. And finally, we perform the acquisition of the image and the interpretation. So the next part, for the next part of the talk, Arun sir will be taking over.
What is about CTCA and how the hardware and the software has changed in the last 2 decades that has enabled us to make the coronary arteries, which is a moving organ in a moving cage. Now with this, we need to know how the data is required. So as a radiologist, we are fortunate that we have a good support from the pediatric allergy immunology unit. So we have a dedicated WhatsApp group, and usually when the patient is decided that you need to go to the CTC, they will contact me or Dr. Arun whether we are available. If we are available, we'll tell them at this time you need to come. Patient comes to the daycare or admitted, whatever the scenario is, and patient comes to the even full resuscitation kit. And believe me, it is so, anybody, any corner of India can contact us, and I can assure you, you will have a flawless experience which you never have thought of it. And thank you, Professor Singh and Dr. Rakesh and his team that they have created this model. And this model has not come in days, it has taken years to come to this stage. I request the young, the DM students have come to respect that protocol that we have made and try to replicate when you go back to your respective places. Once the child is in, depending on the age of the child, requires sedation or without sedation, we train their parents, we train their patients, and then that's how to get good images. To cover these aspects and how we do it, I request Dr. Arun to go forward and let us know, what is our protocol and how we do it.
Thank you, sir. Thank you, Dr. Shrestri, for covering the initial part. So coming on to the data acquisition or the day of acquisition of the scan. So as for any other CT, the consent from the parents of the child is taken, and we have to see for IV access. So the preferable intravenous peripheral venous access is preferred, preferably in the right arm. However, any access these days, whatever access is given, we can perform the CT, but we have to change few parameters. But it is always better if it is close to the heart. Why? Because in that way, from the peripheral venous system, we mitigate the dead space till the volume of the contrast reaches the aorta and it opacifies the coronaries. However, in small kids, it's difficult for access. So any access these days with the recent machines, scan can be performed with some changes in the parameters. What type of cannula? Because the volume and the rate depends on it. So the larger cannula is better because we need to give more flow rate, and a rough idea is the 24 gauge cannula or 26, but then the maximum flow rate, whatever it permits for better acquisition, is we don't have to exceed it 1.5 ml per second, and in generally these small kids 0.5, 0.7 to around 1 or 1.2 is sufficient for acquiring an optimal CT scan. Then the placement of the ECG leads, but then the patient we need to see for then we take the patient for positioning. Patient is, the CT is acquired with the patient position supine and with the sedation. The technician we also have straps to strap the child so that there may not be during the injection, or if there is inadequate sedation or patient fall, it avoids. So we have, please. Okay. And then ECG electrodes are placed when the patient is positioned, and we have to check for intravenous peripheral venous access, and technician, the role of technician here is to check for its patency while always a fresh cannula and to see for continuous flow with minimal amount of saline to see that there may not be any extravasation during the scan, which is rather worse for the small kids. So the scanning it involves various phases. For first is topogram. Topogram just to select the acquisition from which level to distally up to the length of the scan. Then non-contrast calcium scan. The indication have already been told by the previous speakers. So it is done in the chronic phase or in the follow-up, not in the acute phase. And then the angiographic acquisition with different modes, as we will discuss it later, prospective or retrospective, with their advantages, and then interpretation of the scan. Scan interpretation, the particular importance is of curved reformation and volume rendered images, which shows the scan in full length of the coronaries, even on one image of the CT. So we can just see for the calcium score, which there is automated software and it provides the values just at a glance by the color coding system for different coronaries, and anybody can see it with the different color perspective and what is the calcium score. So coming on to the acquisition is done with the as initially told, first the topogram, then the contrast medium protocol optimization, followed by coronary CT angiography. So we start. So the positioning is very important, because if we limit the z-axis, the coverage total from cranial to caudal, only that will relate to the optimal radiation exposure. If unnecessary we cover the larger portion of the body, the radiation will be exponentially high. So we just begin above the carina, and we have to, because to cover the coronary origin, which is well below it, and the ending position is just below the diaphragm, as we can see here. So it is just below the carina to below the diaphragm, to include the that we see all the coronaries. Just below the diaphragm is to see for the distal extent. We may not miss those, and sometimes the kids may move slightly during the examination. That is the main reason we sedate it. So then we have to see for the contrast medium. Contrast medium is that the contrast delivery should be timed in such a manner that we acquire in the acute, in the full aortic enhancement phase. At that phase, the coronaries will be opacified clearly with the uniform opacification, and a saline bolus is given to clear the contrast from the right side of the heart and SPC, because otherwise that will cause artifacts and you will not be able to see those coronaries which are in that direction, particularly the RCA, proximal or mid RCA. So this peak aortic enhancement concept it is approximately the gamma variate bolus geometry. We will see that there is inherent delay as the contrast is in the peripheral venous system, largely unmixed over the contrast injection duration, but it has to reach up to the left cardiac chambers for proper mixing and proper opacification of the aorta, which will give us the better visualization of the coronaries. So as we can see this, if we see the time density curve, it has a inherent delay. That delay amounts to the inherent scan delay, particularly, and followed by the peak enhancement and the temporal window for acquisition. So this temporal window, we have to acquire the CT during this period only. This window can be broadened or can be narrowed depending upon the protocol, how fast we acquire, how slowly the injections are made, or how fast the scan is taken. And this window is proportional to the volume of contrast injected and the bolus injection time. So if the increases, then it can further be increased, which will result in faster, earlier recirculation and poor opacification of the contrast. So optimal opacification during this window is very important. Then the iodine concentration. As these parameters are highly dependent for obtaining an optimal CT acquisition. So the iodine medium concentration, higher iodine medium concentration correlates well to the higher opacification and the volume and rate of contrast administration and timing of the contrast medium delivery. So the volume of contrast can be calculated by estimating the scan delay, scan time, inherent delay 5 seconds for this current scanner, and the flow rate. Flow rate, it depends on the cannula size. Then we can use either contrast bolus technique or the test bolus technique. Here we place the region of interest in the ascending aorta for evaluating the coronaries, and with the bolus we can see its opacification, fix a target of 100 or 120 HU when the opacification of ascending aorta is maximum. At that phase will correspond to the maximum opacification of the coronary arteries. At that time the machine triggers the scan. So we have two modes. It is the prospective gating mode or the retrospective gating mode. In the prospective one, we can see that it is a step and shoot method, and the scanner, it is scanning only during the prescribed period of the RR interval. And so the advantage is it is having a lower radiation exposure, but it requires a stable heart rate. Lower and stable in adults, but at least stable heart rate in kids. Contrary to retrospective gating, which is, if we see, it is a continuous acquisition throughout in the helical mode. And however, so as it is a continuous exposure, it will cause increased radiation dose. Then how to optimize radiation exposure, as we were discussing, because this is the most important aspect, which is limiting the full implementation of this coronary CT angiography in kids, which is the gold standard for adult population. So we have several methods these days to reduce the radiation exposure to sub-millisievert scans. Even half of millisievert is possible with current generation scanner. First is, the most important is reduce the length of the scan, craniocaudal extent of the scan only for the whatever is required. Then limit the FOV. We do ECG dependent tube current modulation. We perform with the current modulation that there is continuous tube current is going on during the whole of the cardiac cycle, but the maximum is during the diastole. And then we decrease the kV, the voltage and the tube current. Nowadays the machines are intelligent enough to have the care dose and care volume voltage setting, which are automatically set as per the patient body weight. And so otherwise in kids we usually do it with the 80 kV. Even we can see even the 20 kV reduction will result in nearly half of the radiation burden. And we do prospective ECG triggering with adaptive sequence. And even latest generation scanners, we have a high pitch helical mode which is very fast and can within one heartbeat can scan fully with sub-millisievert radiation dose. Finally, the reconstruction algorithm using latest iterative image reconstruction method, it results in substantial radiation dose exposure to the kids. So here we see the full tube current. If we see, as I have discussed, that ECG tube current modulation is that it is not going equally all along the cycle. It is high during the diastolic phase and lower during the systole. So it effectively reduces the radiation from 20 to 48% without compromising the image quality, as well as the reconstruction method, which is already incorporated in the software-based systems. And nowadays, these systems, they use only iterative reconstruction methods, because the earlier one uses higher tube current, which then quantifies for the higher radiation exposure. So the take-home messages are that CT angiography is the rewarding once it is done appropriately, and in-depth knowledge of scanning technique and anatomy is important. And always customize your scan with proper radiation optimization to have a least radiation optimal CT scan imaging. Thank you.
Thank you, Arun, for giving us the insights of CT coronary angiogram, how it is to be done, and though the forum is. I think the topic was chosen at least to introduce what is possible, what is available, and how it can be used in routine clinical practice. I would like to make two comments that once you want to do it, first is intent. If you want to do it, definitely it can be done, and I thank Dr. Shrishti that they have taken a lead, and recently they have acquired one case, and I think it has come up very well. So once you want to start with, you can start with congenital heart diseases, and then slowly you can come to the Kawasaki disease, which is not very difficult. It is a matter of time, and definitely there is a learning curve very few. I think it is our intent and it's our heartfelt wish that we have good spots of coronary artery imaging all over the India, and we are committed for that. Anybody who is here or otherwise your friends, you kindly connect to us and we will help them the way we can. In fact, we can go to their sites and personally visit them and get their protocols. If there are any questions, kindly let us know. Please will be more than happy to answer. And Shrishti, can you join here? Dr. Rakesh and Dr. Sukhdeep, please. I think we should have some discussions on this topic.
Before they asking question, I can just start because sedation is always a issue in young children, and how we are dealing here in sedation is that mostly in children above 5 years of age do not require sedation most of the time, and children below 5 in CTCA we use
sedation is triclophos, like this pedicloryl followed by midazolam. So most of the children are like out of 90-95% children will just require a triclophos and one dose of midazolam, and but sometimes that they require a repeated dose of midazolam. So, and the sedation is only for 30 minutes, and they can go home on the same day, like within an hour, child is fine. So, in our experience, we have performed more than 300 patient CTCA. Possibly now it's touching 325. But we have not used general anesthesia in any of the patients. So that is a very important part, because we can, this is a daycare procedure for us.
Dr. Rakesh, on that context, I would like to say, when I studied in University of California, Professor Jainmans asked how you use general anesthesia. I said we don't use general anesthesia. So how it is possible that you use CT coronary angiogram without general anesthesia? That is not possible, at least in their country. And in our experience, we have not used general anesthesia to treat any of the patients, irrespective of the age of the children having Kawasaki disease. So, their teams does a wonderful job, and the